afternoon and welcome to H360 Live. My name is Courtland Long and unfortunately my partner Dave couldn't be with us today, but we still have a very exciting show for everyone. We have two doctors from Mount Sinai Hospital, Drs. Khorasani and Dr. Rosenberg, joining us to talk all about skin cancer awareness and various treatment options. But before we get into that discussion, I just want to review some quick facts about skin cancer so everyone is on the same page. So there are three major types of skin cancer: basal cell carcinoma, squamous cell carcinoma, and melanoma. The first two are grouped together as non-melanomas. Now each year in the US, there will be about 5.4 million cases of non-melanoma skin cancer treated in about 3.3 million people, and 1 in 5 Americans will develop a skin cancer in their lifetime. About 90% of non-melanoma skin cancers are associated with exposure to UV radiation from the sun. And the cost of skin cancer is pretty high. There's about $8.1 billion estimated with skin cancer treatment in the US, about $4.8 billion associated with non-melanoma, and $3.3 billion for melanoma. Well, doctors, thank you so much for joining me today. We're really excited to talk about skin cancer awareness and treatment options. So,
thanks for inviting us.
Yes, thank you for coming in. Now, I know that you're both surgeons at Mount Sinai and you work very closely together, so can we start out by having you both sort of explain your different areas of expertise?
So I'm a facial plastic surgeon. I do cosmetic and reconstructive surgery of the face, the head, and the neck. I also train in head and neck surgery, so I do large head and neck surgery or head and neck cancer operations. Dr. Khorasani and I work together in terms of both diagnosing, treating, and reconstructing patients who've had skin cancer removed surgically. A typical patient will be a patient who's come in, they've been diagnosed either by their local dermatologist, a head and neck surgeon, or myself or Dr. Khorasani with a skin cancer. It's been removed, let's say, on part of their nose or their cheek, which Dr. Khorasani's done, and then that patient needs to have that area reconstructed, and I'll come in and reconstruct that area.
So Dr. Khorasani, a patient comes to you and you diagnose a skin cancer and then you bring Dr. Rosenberg into the case?
That's right. So not all skin cancers are treated equally, obviously. Depends on the complexity of the case. So when somebody has a biopsy-proven cancer, say on their nose, they tend to come for micrographic surgery when we use a microscope to chase the roots of the tumor. Has a very high cure rate. And once we remove the skin cancer, then the second stage includes reconstruction. If it's something that is small, usually can be in the office. Something more complex is sent to Dr. Rosenberg. There are instances that we have patients that have very complicated tumors, such as larger squames on the scalp, or something that actually need a multi-specialty approach. So we are all part of a multi-specialty group. We present our cases. We have a medical oncologist, surgical oncologist, we have a radiologist, we have a pathologist, and we have dermatologists who kind of give their input, and the tumor board then decides what should be the next appropriate step for the patient.
So you're leading me perfectly into my next question, and we know that Mount Sinai has a very collaborative approach. So what are the benefits of this collaboration for patients?
So it takes some of the pressure off, from in terms of the surgeon, treating surgeon. When a case is complicated, it's always takes some of the pressure off your shoulder when you have other colleagues who can help you treat the patient. You make sure that you're doing the right thing by getting different opinions, and patient get the best of all, different specialties. And I think having a close collaboration with a pathologist, with a diagnosing dermatologist who actually was there and biopsied it, with derm surgeons, which I am, and the facial plastic surgeon, it really gives the patient the best care possible.
So, go ahead.
I was just going to say that, cancer is an incredibly complicated disease. And the best treatment for patients with cancer is what we call multidisciplinary treatment, where all members of the treatment team are working together in the same group diagnosing and treating these cancers. So that includes us, the surgical oncologist, the medical oncologist, the radiation oncologist. We all get together, we're all colleagues, we all meet once a month, we all talk about every patient and make sure they all get the best possible care. So that's really one of those group advantages.
Mm-hmm. Now, it's very true, cancer is a very complicated condition, and there's 3 different types of skin cancer. I'm sure there are subtypes to all those as well. So can you give us a brief overview of the 3 different kinds of skin cancer?
Absolutely. So the majority of skin cancers that are diagnosed in the U.S. are usually basal cell carcinoma. Basal cell carcinoma is a malignant tumor, but it's generally speaking not metastatic. So if you leave it untreated, it can keep growing and destroy the local tissue, but it's very rare that it spreads other parts of the body unless we have an immunosuppression, so it's a transplant patient or HIV end stages. So that's the most common, very highly curable, you know, and it's not metastatic in the sense of, you know, you have to really worry about your life. The second one, most common, is squamous cell carcinoma. Now, squamous cell carcinoma, again, depends on the location and the size. Some of them are very low risk. It's kind of a spectrum, very superficial, not very, almost even easier to treat them than the basal cell. And some of them are more invasive and very aggressive. So that's a squamous cell, and usually about, I would say about 10% of them have a chance of spreading to other parts of the body. And then you have melanoma, which is the least common, but the most deadly of all. It's made from the melanocytes, or these are cells that are supposed to protect our skin from UV radiation. These cells, when they start growing abnormally, they can cause problems. And then melanoma, unfortunately, can spread other parts of the body, and about, you know, more deaths are contributed to melanoma than any other skin cancer. There's about 9,000 deaths a year.
Wow. So, you know, we have some questions later on the show that are going to circle back to that, but for people who are new to H360 Live, normally every week we send our interns out into the field and they get reactions to New Yorkers about some of our health tips and things that we give. But this time around we have a different format, and we had New Yorkers ask questions for you guys to respond to. So let's go ahead and roll that first video clip.
Hi, I was wondering, what is the mortality rate for skin cancer?
What are the signs of cancer? That's my question.
So 2 good questions right there, one about the mortality rate, which you covered a little bit, and the other about signs of skin cancer. So I think since you already covered mortality rate, why don't we talk about some of the signs of skin cancer?
So some of the signs of skin cancer include, you know, you have a pimple you didn't have before, and suddenly a pimple has been hanging around for like, it's been 2-3 weeks. There is a spot on your face when you're shaving, keeps bleeding on the same spot. You had a mole that was perfectly fine looking, but suddenly starts to maybe peel, or the top portion of it start to blister. So there's a change in any spot on your body. It's the most important thing. To change is the key factor.
Mm-hmm. So going back to mortality rate and the curability of a lot of these skin cancers, can you expand on, you know, how curable is skin cancer?
Yeah, so basal carcinoma, and you know, specifically when you're talking about, you know, a lot of them occur in the head and neck area. With micrographic surgery, we are reaching about 99.5, some studies 95.6, depending how you're looking, percent, and so that's a really, really high cure rate. Similar for squamous cell carcinoma, it could be a little bit, probably more, in like a 98%. And then, you know, melanoma, it all depends on the depth. It all depends how deep these cells have extended down into the skin.
Mm-hmm.
The most top part of the skin is called epidermis, so all the melanomas in that area is called in situ, so stage 0. And as they go down deeper in the dermis, you get more and more invasive, less cure rate. So like stage 1, which is the most common, we still see about 90, you know, our, when we're looking at our charts, that are over like 97+% cure rate for that. Mm-hmm. But of course, as the stages goes down, or as the stages go up and the depth, you know, goes further down into the dermis, then your cure rate goes down more and more.
One pitch for prevention and early diagnosis, when you look at cancer in stages, you look at the prognosis, stage 1 is early stage cancer, and this is for all cancers, and specifically skin and melanoma. The cure rate is high, above 90%, above 97%. But as you go down, you get to stage 4, which is when it's spread to all other parts of your body, or other parts of your body. And for melanoma, that cure rate is less than 30 or even less than 20%. And it's not necessarily a cure rate. We look at what's called 5-year survival, and the 5-year survival is very low. So if you're ever suspicious of anything, this is the ultimate proof in numbers that it pays to get it checked out early.
Absolutely. And so surgical options for skin cancer treatment, what are they and which do you two specialize in?
So the 2 treatment options are either, for most skin cancers, are either what we call wide local excision, where we just draw a circle around it based on a certain size, based on a number of factors, including depth and size of the cancer, and we just cut it out and send it off to the pathologist. They look at it and they say, okay, it doesn't look like the cancer is spread anywhere to the margins of this, it's clear, and then we reconstruct it. Dr. Khorasani, and he's going to talk in greater depth about this, specializes in a special technique called Mohs micrographic surgery, where he's looking at all the margins of the cancer while he's removing it. And that has many advantages, especially on the head and the neck, where a lot of cancers, or the majority of non-melanoma skin cancers occur, and where a millimeter of difference or a centimeter of difference is a huge difference when it's on your cheek or your eyelid. You want to talk about Mohs?
Yeah, so the main difference between excision and micrographic surgery is the way we process the tissue. That's the key factor. So we are able to basically occasionally only get a millimeter past the tumor and clear someone, versus traditional excision tend to be much larger. We have to do like 6, 7, 8 millimeters, sometimes more. So the way when we do an excision, and that tissue is sent to the pathologist, is kind of like a bread loaf. And we usually take a slice of bread from the beginning of the loaf, one in the middle, one at the end. And then that is processed. And that usually is only about 2% of that whole tissue. Usually gives a very good representation, but however, we're not looking at everything. In Mohs surgery, because usually we're dealing with the head and neck, the area, the tissue that is removed, it's much smaller, so we can actually process the entire surgical margin. So we're getting basically look at the entire margin and the depth. So we look at 100% of margin as opposed to about 2% of the margin. Because of that, it's much less likely that we miss a root that is extending to areas that wasn't checked.
So I know we have some more questions from our New Yorkers in the field about other treatment options. So why don't we go ahead and roll that video clip?
So who's most at risk for skin cancer?
I was wondering, what are some of the non-surgical treatments for skin cancer?
So before we get into the further treatment options, one of the questions was, who is most at risk for skin cancer?
Number one is a personal history of skin cancer. So that's number one. Usually other risk factors, familial risk factors, is a genetic, fair skin, freckled. There's a couple of papers that we recently wrote about patients that have a lot of moles in terms of based on mole count. So if you have, generally speaking, more than 9 moles on your right arm, generally speaking, you're a little bit higher risk. Fair complexions, basically.
You're singing my song, Dr. Khorasani.
Yeah.
So the second question in this video clip was non-surgical options for skin cancer.
Yeah.
Are there any treatment options available?
Absolutely. So we have creams. The least aggressive of all skin cancers, which is the basal cell carcinoma. If you have a superficial type of skin cancer, which means, again, this is not invading the dermis, this is just the top portion, and squamous cell carcinoma in situ, you can use creams. There are multiple different creams. Some of them stimulate your own body's immune system to attack the cancer. Some of them actually chemotherapy that you actually apply to the top of the skin, and the cancer is destroyed. We also have lasers. They tend to also be a little bit more invasive. They're not non-invasive necessarily, but lasers are also used occasionally for, key is the depth again here, how deep the cancer is going into the skin.
So Dave, my colleague who couldn't be here today, he left a couple questions he wanted me to ask, and one of them was, how do you decide which cases do you guys use surgical treatment options and non-surgical treatment options? And it seems like it's based on the degree, the stage of the cancer and which form of
Exactly.
cancer it is.
Yeah.
Cancer care in general is fairly regimented. We have, a large volume of literature dating back decades that really delineates staging, treatment options, what's best practice, what's not, what leads to the longest survival. For skin cancer, the best part for most patients is it's usually eminently curable with surgery alone. And there's rarer patients who need to go on to what we call adjuvant therapy, chemotherapy, radiation, immunotherapy. Dr. Khorasani and I generally work together. We know the patients ahead of time just based on the size of their cancer and what they have, on whether they just need surgery or whether they're going to need more. We do see a subset of patients, and these tend to be older patients, neglected patients, or patients who are immunocompromised, especially patients who had organ transplants where they have to be on medication that lowers their immune system, who have very large, very aggressive skin cancers. And those patients, not only do they get surgical treatment, that may involve Mohs surgery, wide local excision. It may involve long operations in the operating room that involve major reconstructive procedures and other tissue transplants from other parts of the body. But that also involves, after the fact, chemotherapy and radiation. And those are a kind of patient that at a big academic center like Mount Sinai with a big team, we tend to specialize in. And we see a fair amount of that.
So you guys have covered already some of the risk factors associated with skin cancer. Are there, and I was really surprised to learn about organ transplants being more susceptible. Are there any other risk factors out there that are associated with skin cancer?
So there are rare genetic mutation that, where we know that patients get more skin cancer, like Gorlin syndrome is being one of them. They get multiple basal cells. They're very rare, but I think something that we do see extremely often nowadays is transplant, because nowadays we are getting better at doing transplants. We have medication that keep them alive, but unfortunately it suppresses their immune system, and we're seeing an increased amount of skin cancer. But the immune system, and that tells us how important the immune system is. And as we know, anything that will reduce your immune system, such as stress, whether if it's from work or whatever stress it is, we know that will reduce your immune system. And of course, every day when you're getting this little mutation, your skin cancers are in check with your immune system. And if you have a bad immune system, that's where things go the wrong way.
So skin cancer is becoming a little bit more common, is what I'm hearing.
Right, exactly. And that's one of the issues. I mean, if you think about it, in 1930s in the U.S., the risk of melanoma wasn't like 1 in 1,500. Now, white Caucasian in the U.S., risk of melanoma is about 1 in 50. That's pretty big jump. And there are many different things we looked at. I think obviously we have an aging population. We have a travel patterns of people didn't spring break in Florida probably in the 1930s as much. And there are but even when we take everything into account, we still cannot really understand why we have such an increase. Melanoma is like #1 fastest growing cancer in men, and number 2 fastest growing in women. So it's very difficult to really still understand what's going on, and there are different theories. So indoor tanning beds always get a really bad rap for skin cancer and premature aging. How big of a role do these play?
It's like smoking for your skin. I mean, it's highly carcinogenic for the skin, and sometimes it's hard for patients to. That's a kind of a long-term thought, and people tend to think in the present. Well, the other thing is it's horrible for your aging. It's going to, over a very short amount of time, make you look older, tired, wrinkled, all the things people want to avoid. So if the cancer part of it doesn't motivate a patient or someone I'm talking to, I always try to highlight the aging part of it, because it's bad on every level.
So there's a campaign I see all the time, I think, in the subway, and it's about indoor tanning beds, where it says tanned skin is damaged skin. Is that true?
Yeah, so your skin, you have skin cells, and the skin cells have DNA, and And then that DNA, when you go in a tanning booth, you're radiating your DNA. And you're damaging it. And usually, luckily, we have repair mechanism and that take care of our DNA. But it, like any cancer, is a multi-hit. So you get one hit when you go to the spring break, and then you get the second hit when you are in the tanning bath, and then you already had a hit from your mom because she had basal cell when she was younger. So now you have 3 hits already, and then you got a 4th hit, and that's it. Then you develop a skin cancer. So that's something that patients have a hard time understanding. Wait a minute, if I was a lifeguard in my 20s, why am I getting 100 skin cancers a year suddenly?
Yeah.
Now, like 50 years later.
Right. Well, we have one more round of questions from
Yeah.
our New Yorkers, and they're all about prevention. So let's go ahead and roll that clip.
If there's any prevention, do we have prevention, like prevention cares?
Okay. So how often are you supposed to reapply your sunscreen when you go to the beach?
So the big question of the day, how do we prevent skin cancer?
The good news is it's fairly straightforward. So it's as simple as making sure that you use an SPF 30 moisturizer or sunscreen, and that when you're in direct sunlight, you take reasonable precautions. You wear a hat, you don't expose your skin for an inordinate amount of time, and you avoid blistering sunburns, regular tanning.
Yeah. Frequency of applying is much more important than the SPF. The number of the SPF is purely a marketing thing that happened about 5-10 years ago, and I think we're getting away from that. But unfortunately, still out there. So frequency is very important. If you keep jumping in the pool in your area, but you're by the beach, the stuff is just rubbing off. So making sure that reapplying more frequent. And protective clothing, which I think Dr. Rosenberg discussed as well, is very important. Some of the other stuff is just avoiding the sun when the UV index is really high. You don't want to go necessarily run between 11 a.m. to 2 p.m. That's just not what I would recommend. So you want to either do it like 6, 7 a.m. or you want to wait until like kind of sunset at time, and then you can go for your run.
And so how often should you reapply sunscreen, even if you're not just jumping in the pool all day?
So recommendations really every 30 minutes. I mean, it's not even
No, that's not a
dermatologists
marketing
probably. Yeah, that's something that when you're outdoor and there's a sunny area. I would say most of us will like you to apply like a moisturizer on your skin with a SPF on it before you go out and about, even if it's not sunny out. And then if you're going to having lunch again, reapply at lunchtime. And then if you're going to go for that run, and when you got home, right before your run, you want to reapply that sunscreen. So just adding it more to your routine daily life, even though you're living in an area that is not super sunny, you're still getting UV radiation through the cloud. Nothing to do with the temperature of the ambient temperature or clouds. You're still going to get a lot of UV radiation.
It's hard. I'm always really clear with patients. I know that, chasing your kid and putting sunscreen on every 30 minutes at the pool seems ridiculous, but the benefits that you accrue through the rest of your life are immeasurable. We really try to focus on that, to be realistic about, what you want.
Well, does it matter if it's the spray sunscreen versus the old school lotion sunscreen?
I think Dr. Khorasani can probably give you a better educated answer to this. My impression is that when people put spray sunscreens on, they very rarely apply the appropriate amount in the appropriate areas. And I don't know if there's research that points to that too.
Yeah, so again, we're getting a little bit away from the sprays recently. There have been just some other issues with them that are sort of been surfaced, and I don't think we'll have time for it here now. But I would say the best thing for you is whatever you feel works best on your skin. And there are many different, and unfortunately, a lot of the bigger sunscreen companies, they always have, they're making the biggest ads. They are not necessarily best sunscreens. So just kind of, read some reviews online and see whatever works best for your skin. There's now some moisturizers that just feel exactly like moisturizer without SPF in it.
Yeah. And
try to not maybe necessarily look at these bigger brands that you see all over the pharmacy or all over CVS, because sometimes they're not the best. And I can't just tell you the names, but I would say do some research and look at some of the smaller brands.
So at Healthy 360, we think it's really important to be your own best advocate. If someone wanted to do a self-skin exam, how would they go about doing that?
So the best time is to do it on a regular basis. So maybe like for ladies, you know, right after a cycle and like just figure out a day that is good. Combine it with your breast exam, which is really equally important in women. And just kind of, you know, just make sure that you stand in front of the mirror. If you have a partner, make it into a game. You can like check each other. And everybody have iPhone nowadays. If one of them most look funny, take a photo of it, and then compare it in a few months with your iPhone. There are many different apps that you can actually take it before and after and just have it next to each other. And you can actually compare it. I think one of them is called Diptyque, and I don't work for them, and there's no conflict, but I like it because you can actually, you know, look at your mole a month before and a month after, and then you can actually see the change. So there's a lot of stuff you can do. There are a lot of cool apps out there that patients can look for and use the technology to monitor their own moles.
And what happens when someone goes in for a clinical exam with their dermatologist?
So usually it's very important to remove everything, okay? And that's probably the hardest message to get out there because you have skin everywhere. When somebody comes with a high risk, I mean, you need to have every place checked, areas that sun doesn't shine. So remove all clothing. You know, this is not a time to, you know, dermatologists look at skin all day long. So make sure everything's up, remove all the jewelry, make sure you don't have your necklace on, your watch, you know. If you have nail polish, make sure your nail polish is removed at least once every 2 years. I know it's really hard. The hardest thing to get women to do is remove their nail polish. You know, that's definitely the hardest part. So, you know, you have to just realize that you have skin everywhere. And make sure that, you know, you go somewhere that they will take the time to do it. If, you know, if the dermatologist didn't look at your scalp, make sure next time you see him, point it out. You know what? Last time you didn't really check my scalp. Why don't you take some, do you mind just checking it a little extra this time?
Yeah.
Because, you know, nowadays we're sort of all very busy and running behind schedule, and, you know, if you didn't look at certain areas last time, if you know, didn't have time to check under your bra, next time you see him, say, hey, can you please check there, because you didn't get the check last time.
Well, you'd both be very happy to know I got a skin check last week. Skin cancer runs in my family.
Perfect.
So I try to be very proactive.
Excellent.
And during this exam, my dermatologist calls out some words and numbers to the nurse. She marks it on a chart. And he calls out things like angioma, injunctional, things like that. Can you explain what those mean? Yeah,
so very common skin spots that we all have. So angiomas are little blood vessels, little growth of little small capillaries, benign. Junctional nevi just mean like your average mole that we have. Intradermal nevi, a little bit, they're raised moles. Junctional nevi are more like flat. There are certain vocabulary that we use when we do a skin check to differentiate what's normal and what's abnormal. And I think it's very important to know that, you know, no matter what your history is, you should definitely get skin check once a year. If you have history of skin cancer, or yourself or your family is a strong skin cancer history, you should do it twice a year. And again, you know, make sure that they look absolutely everywhere.
So Dave's last question from the road for you guys is there a reason that more men develop skin cancer than women and are more likely to die from it?
A lot of it's habitual. So men are just less likely to put on creams and ointments, and that's what sunscreen is. So that's step one. Step two is, this is not just skin cancer, but throughout all of healthcare. Men just go to the doctor less frequently. They do less primary or preventative care, especially when they're in their you know, early adulthood or even middle age. And thus, they find out about their skin cancers later when they're more advanced, and then, as we know from our discussion about prognosis, potentially more fatal. There may also be a biologic relationship. There are some studies that have shown that men, when you control for these other factors, still fare worse when it comes to mortality. But no one really understands why, and that's a small percentage. the majority of it's still habitual.
Dr. Khorasani, I think we'd be remiss if we ended the show and we didn't cover the ABCs. So could
Absolutely.
you say those for our colleagues?
So ABCs are very important. You know, this is again something you can do when you do your self-examination. So A stands for asymmetry. So I usually use my own mole to explain to patients, but you draw an imaginary line through your mole, and if one side matches the other, that means it's symmetric. Simple as that. B stands for border. You want the border to be fairly smooth. You don't want any jagged borders, any irregularities. So that's B. C stands for color. You want to have a uniform color. There are occasionally you see a mole, it's a little bit brown, uniformly brown, but then right in the center, it looks a little bit like more pitch black. And those are the one that you are concerned about. So that's C. D's diameter, not super important because we can have very small moles that can actually turn bad and very large moles that are totally fine. We're born with them. So it's not the most important, but about 6 millimeter, it's sort of like a kind of anything larger than your pinky, you want to kind of keep an extra eye on. Most important is probably the last one, which is you know, anything that is evolving, okay? So E, evolving, change, and that's what I was trying to talk about earlier. They're probably the single most important factor.
Great. Well, thank you both for joining us today. I think this was a really informative discussion.
Thank you for inviting us. Yeah, and if anybody has any more questions, we have a multidisciplinary website, Mount Sinai Skin Cancer, and there is really a lot more information for them to be able to upload and get any good up-to-date information.
Wonderful. Well, thank you. I'd like to thank our viewers for tuning in and our sponsors for making it all possible. All of our episodes can be found on demand at healthy360.com, and our podcast can be found in the iTunes Store. We love social media, and we're all over Facebook, Instagram, Twitter, and Pinterest using the hashtag #RealStories when posting, and we'd appreciate it if you would do the same. On behalf of Dave Duplay, myself, and the entire Healthy 360 family, we'd like to thank you again for joining us today, and we look forward to seeing you next week when we're chatting with Laura Friedman and the Hearing Health Foundation.